The American Rehabilitation Educational Network presents Clinical Update, dedicated to meeting the continuing education needs of rehabilitation and healthcare professionals. Clinical Update is a growing series of informative, useful videotape excerpts from Aaron's monthly video conferences. Applying the talents and expertise of distinguished faculty members from around the world, these programs are specifically designed to provide concise, clinically accurate knowledge for use within the daily practice of physical therapists, occupational therapists, nurses, psychologists, speech pathologists, physicians, and other healthcare professionals. This program, The Biomechanical Sources of Back Pain, Anatomy and Physiology, features Sandy Burkhart.
Sandy, a lot of epidemiological studies of back problems have been conducted and a lot of statistical data obtained. What do the results tell us about the significance and the effects of back problems?
Well, it's a very, very big problem, and it's responsible for more work days lost than probably any single disease process. In fact, it's been calculated that 100 working men will lose about 146 weeks of work due to low back pain.
Wow.
Which is very significant. There are a number of workers who are very prone to back pain, and we can look at the slide if we could, please.
These are the high-risk workers that we're talking about here. Okay, we'll have that in just a second. So, oh, here we are.
Yes, truck drivers are very prone to low back pain, as well as heavy manual laborers, as well those who are referred to as material handlers. It's very surprising that nurses and nursing aides have a very high incidence of low back pain.
Because of lifting, is that?
Mostly because of lifting and incorrect lifting. In fact, at West Virginia, we're looking at doing a complete education program for the nursing staff just to avoid this particular problem.
And with the truck drivers, I assume it's because of long periods of sitting in one position?
That's right. Sitting is probably the position that contributes most to low back pain. And of course, they're in that static position while they're driving, and then they get out and the muscles are fatigued. And then if they try and lift something on the truck or move in an inappropriate way, then they're very vulnerable to back pain.
Will you run through for us some of the factors that contribute to low back pain?
Yes, I put together a list here now in relationship to those things which I think are very important. First of all, muscle fatigue. And probably the muscle is probably the biggest single structure that needs to be looked at in relationship to the cause of back pain. Postural stress and abnormal stress, trauma, the socioeconomic and emotional stresses on personality. Some people have a very weak type of personality. They're very prone to pain. A little bit of pain causes them a lot of distress and a lot of disability. Degenerative changes, osteoarthritis of the spine due to aging or to repeated trauma. There are a number of congenital defects like sacralization of the fifth lumbar vertebra, spina bifida. Spinal and intervertebral foraminal stenosis involving changes in the spinal canal or in the intervertebral foramen itself, compressing the nerve root or the spinal cord elements. There are genetic factors. There may be nerve root irritation or ischemia, and then there may be associated neurological dysfunctions. The duration of the symptoms are extremely important. If they last more than 3 weeks or even more than 6 weeks, then we begin to consider it to be chronic. And there are many patients who have pain a year or 2 years that haven't been able to be treated by conventional medical methods. Physical fitness is important because many of these patients are not fit. And so a good rehabilitation program has to include a general fitness program. And that also includes body awareness because they need to develop the motor control to handle their body in different work and living situations.
Okay, so clearly we are dealing with a complex problem then, but not everybody is agreeing about exactly what the source of the problem is. Will you summarize for us the various views that people hold about the source, or maybe I should say the sources of back problems?
The primary source that most people look to is an anatomic source, whether the problem is coming from changes in the intervertebral disc or from degenerative arthritis of the spine, which could lead to stenosis of the foramen or the canal. There could be a congenital type of problem. Some look to a ligamentous strain, some look to a muscular sprain, some look to facet types of pathologies involving either a facet synovitis or swelling of the joint or a subluxation. And many of the chiropractors put their whole theory on the subluxation. There can be nerve compression, and there could be a tumor that could be the cause. Some look for sources from posture, fatigue and inactivity, the behavioral source in relationship to whether it's all in your head, an occupational source where it might be job related, or a physiological source where it's a problem with motor control.
And in many cases, you told me when we were chatting before the teleconference, we simply do not know what the source is.
No, we don't.
Clinically.
I suspect that if we only know the actual source of the patient's pain in about 15% of all the patients that we see. And so we try and come up with a clinical diagnosis and design a treatment program accordingly. That's why we've kind of gone away from that aspect right now and go to the signs and symptoms that the patient presents, and then to try and modify those signs and symptoms with a treatment program, irregardless of the pathology.
Well, given the uncertainty about the sources of the problem, in general, how does a therapist evaluate and localize a problem? Are there any standard procedures, or do they vary?
Well, there's great variability in the examination procedures, and I think the physical therapy profession in itself right now, as well as the medical community, the chiropractors and the osteopaths, are confused about how to exactly evaluate a back. Many of these patients are better within 3 weeks anyways, so maybe the evaluation system isn't very good at all. But there's a standard medical model. We try and look at the x-rays, do a neurological exam, maybe look at CAT scans, myelograms, discograms, EMGs. This, again, will only give us a diagnosis in about 15% of the cases. There are other forms of evaluation, including the postural examinations, such as what Florence Kendall has advocated for many years. Some look at pain behavior and spinal movements. McKenzie, Maitland, Kaltenborn look at the movement of spinal segments in relationship to the production or elimination of pain. The osteopaths like the mobility testing and muscle energy kinds of techniques. Then there's an activity of daily living type of evaluation, and also an ergonomic evaluation in relationship to the job. And I think what we need to do is to develop a standardized evaluation form. NIOSH, National Institute of Occupational Health and Safety, has contracted physical therapists, 5 of us, myself, Richard Earhart from Pittsburgh, Rick Bowling from Pittsburgh, Steve Rose from Washington University in St. Louis, Roger Nelson, who's at NIOSH, and Bill Fromhurst, to develop a computerized, standardized low back evaluation form. And we will have that completed on August the 15th. And we'll be ready for field trial, hopefully in late 1984.
That is exciting.
Well, it is very exciting from the standpoint that it will be all computerized, so that we'll be able to put it right in the clinic and have the evaluations put on disk and then modem into a central computer for data collection. So we'll be able to test this evaluation form very well.
Terrific. Okay, we also know that a variety of treatment modalities and techniques is being used, ranging from the passive to the aggressive, again in sort of a viewer's digest form. Can you tell us a little bit about what techniques are being advocated today? Well,
in 1934, Mixer and Barr described the first intervertebral disc protrusion. And of course, we went from conservative management to surgery. And then the orthopedic surgeons put in the concept of osteoarthritis and arthrosis of the joints. And so we've gone around 360 degrees and back to conservative management. Not one famous researcher in back pain has developed a significant approach in the management and treatment of back care. And probably the physical therapists are probably the best group of people right now to bring together all the various aspects of exercise, all the various aspects of use of soft tissues and modalities to the forefront to be tested in relationship to proving that we can affect back pain. The kinds of programs that are common, of course, are the use of medications, bed rest, modalities, ultrasound, hot packs, flexion exercises, extension exercises, manipulation and or mobilization, different forms of traction, including bed traction, mechanical traction, positional traction, manual traction, auto traction, all different forms of traction, immobilization with corsets, postural awareness, fitness, education, are all the common conservative methods. Then we have chemonucleolysis, the chemopat pain injections, and surgery. So what we have to do is identify which patients will respond to these different groups. And we need to do research to determine this.
Sure. Okay, Sandy, what I'd like to do now is shift gears a bit and narrow our discussion, because in order to understand any form at all of musculoskeletal back pain, we need some knowledge about the functional anatomy of the spine. I know that at WVU you teach anatomy, and at the risk of making you blush, you are considered by your colleagues to be an expert anatomist. Will you give us a mini lecture on your own views about spinal dysfunction? What components are involved, what are their relationships, and what happens when those components are injured?
That'll be fine. Thank you. I think where we ought to start out is basically looking at the spinal unit. The spinal unit is defined as the vertebra, the ligaments, the disc, the facet joints, the muscle, the innervation, and the blood supply, working as an anatomical physiological unit. You cannot separate any one of these structures from the other. If there's going to be dysfunction of the spine, all these structures will be affected. So we can't narrow our thinking down to one particular tissue. What I would like to do is to break down these units. First, starting with the ligaments. The ligaments function in attachment, they permit movement, they limit movement. We can see that they have names, anatomical names, anterior longitudinal, posterior longitudinal, ligamentum flavum, interspinous, and supraspinous ligaments. They have the ability to adapt by shortening or lengthening, and Mackenzie put some of his weight on this adaptation of ligamentous structures. They maintain a positional relationship, and they're very, very important in the whole process. Here we see a sagittal section of the intervertebral disc. The disc functions to attach adjacent vertebra. It resists shear, and as the vertebra rotates and slides, it provides limited movements. It absorbs pressures. It spreads pressures over vertebral end plates. It spaces and positions the vertebra. The disc, as you see here now, is in cross-section. The nature of that disc is it has a very high water content, almost 88%. It's rich in proteoglycans. It has a lot of collagen. It's sparsely cellular. The vessels are only at the periphery, so its nutrition comes from an indirect blood supply. There are no nerves or receptors. There can be no nerves or vessels in the system because it's always under compression. These are the cells that form the or control the growth and maintenance of the intervertebral disc. The disc has basic constituent parts: cells, collagen, proteoglycans, and water. Each of these component parts has specific functions. The cells are responsible for synthesizing the collagen and the proteoglycans. The collagen provides strength and flexibility, and the proteoglycans and water gives the disc the ability to resist pressure, recover shape, distribute the forces, as well as to provide the watery type of environment to maintain the viability of the cells. These cells have a number of problems. The cellular problems that we commonly see, of course, are for the disc is that they are some distance from their blood vessels. They have an indirect direct nutrient pathway. There's a very dense matrix for the fluid to diffuse through, from the bone marrow, the cartilaginous end plate, to the nucleus pulposus, to the cells of the annulus fibrosus themselves. There's a lot of matrix and very few cells to maintain it. If there were a large population of cells, or these cells were able to increase in number, we would be able to maintain the disc in a healthier state. The matrix is disrupted continually by mechanical pressures. The matrix is also degraded in the inflammatory response by extraneous chemicals from lysosomal types of organelles. The cells then must combine and balance in three roles: matrix degradation, collagen synthesis, and proteoglycan. And if the cells can't work, then the disc will break down.
Okay, and then we have the age changes that we're talking about.
Yes.
Yeah.
Over time, the disc will begin to change. And the kinds of age changes that we see most often, of course, is that the disc will lose some of its water. Not a lot. It'll drop down to about 70%. There'll be less proteoglycans, and there'll be decreased amounts of chondroitin sulfate and an increased amount of keratin sulfate. The change in the chemistry of the disc changes its physical structure and helps to weaken it. The nucleus will undergo fibrosis, and therefore the forces will be distributed very poorly. There's less collagen being produced, and what is produced is of poor quality, and there'll be very, very few cells because they die from either being overworked or age, from the aging phenomena, and therefore there'll be very few cells to maintain it. This just shows you what happens when the disc begins to degenerate, in which case the annular fibers begin to soften, and the concentric layers of the annulus now begin to come apart, and the disc begins to protrude into the intervertebral spaces. But what happens then with the old and the new? Well, the old disc now is relatively drier. It's less resilient, it's thinner, it's out of shape, it's torn, and it's cleft. And this is just showing the intervertebral disc with a relatively small bulge. What happens when the disc begins to change is it changes the overall functions of the disc. You get reduced separation of the vertebra, you get improper positioning of that segment, there'll be alterations in the movements of the joints, there will be reduced absorption of forces, poor redistribution of forces, and then the protrusions. This is a relatively simple one. This is a more difficult case where the nucleus pulposus now is into the softened annulus, and so it migrates in and out. This patient may have several episodes of back pain in 1 year. And so our job will be to get it back into position in the nucleus and hold it long enough until the annulus fibrosus heals.
And heal, yeah.
This is a sequestered nucleus, in which case what has happened, the nuclear material in the center has come out through a hole, much like squeezing toothpaste out of a tube. Once
Tough
it's
to
out,
get.
you can't get it back in. The only treatment for this, of course, is surgery. When we look at the facet joints, and the facet joints are synovial joints, they're